Hey everybody, Dr. Lakefield from Vet Triage here. We are talking about equine today, November 2024 edition of Veterinary Surgery. And let me move this a little bit. Okay, so this is going to be a tough one. Effect of breed, obturator type, and surgical experience with tenoscopic portal creation into the digital flexor tendon sheath in horses. So this is going to be a cadaver study. And a lot of this anatomy, unless you know it very well, it's going to be difficult to get through it. So I'll do the best I can and show you all the pictures, of course. This study does come out of the veterinary school in the United Kingdom, and 2 veterinary schools in the UK, and let's get into it. And there are folks who do fancy this stuff, equine medicine, but not just equine medicine, scoping. This should be a pretty interesting one for you. All right, objective. To determine the influence of breed, so cob and non-cob, obturator type, and surgical experience on the number of attempts, time taken, and iatrogenic damage created when entering the digital flexor tendon sheath tenoscopically. So cob and non-cob are breeds of horses. The iatrogenic damage means damage that's caused by the physician. And then the digital flexor tendon sheath is a very common area of trauma and disease and what have you in horses. It's a prospective experimental cadaver study, 104 cadaver limbs, so 100 is not bad. 100 plus is pretty decent. They used a conical obturator, a switching stick, and they compared those two devices by a boarded surgeon and a surgery resident. Results. The mean cob skin thickness was 8.4 millimeters, nearly twice that of non-cob limbs at 4.5 millimeters. The mean digital flexor tendon sheath entry took longer in cob limbs, 133 seconds, compared to non-cob at 112 seconds. The boarded surgeon's mean entry time in cob limbs was 115 seconds compared to 46 seconds for non-cob limbs. The cumulative iatrogenic damage was greater in cob limbs, so 25 of 52 limbs, compared with non-cob, which is 14 out of 52 limbs. No difference was noted between the obturators, so that's the conical obturator or the switching stick. Surgical experience, reduced attempts, and time entering the digital flexor tendon sheath. Conclusion. Surgeons take longer to enter the sheath in the cob limbs and more cumulative iatrogenic damage is created regardless of obturator type used. Therefore, skin thickness is a major determinant of time taken to enter the sheath and increase the risk of damage. Awareness of the challenges in cob limbs is important. So that's the summary, if that's all you want to hear from this. All right, introduction. Endoscopic examination of the digital flexor tendon sheath is a commonly performed surgical procedure for diagnosis and treatment of septic and non-septic tenosynovitis in all breeds of horses. A comprehensive evaluation of the sheath is carried out by creating the tenoscopic portal between the palmar and plantar annular ligament and the proximal digital annular ligament, 3 to 6 millimeters, palmar or plantar to the neurovascular bundle with the horse in dorsal or lateral recumbency. Following distension of the sheath with sterile isotonic fluids, a surgical incision is made through the skin and the sheath wall into the sheath. Subsequent introduction of the cannula and conical obturator should be met with minimal resistance, but in thick-skinned horses like cobs and draft breeds, and in horses with chronic lesions of this area, anatomic landmarks could be difficult. Furthermore, in cases of chronic tenosynovitis, the superficial digital flexor tendon can adhere to the sheath wall, thus increasing the risk of iatrogenic damage during the creation of the tenoscopic portal. Proposed strategies to minimize the risk of iatrogenic damage are creating the arthroscopic portal closer to the neurovascular bundle, meaning more dorsal compared to the center of the outpouching, the use of mosquito hemostatic forceps to improve the separation of skin and sub-Q, or creation of a tenoscopic portal proximal to the fetlock canal. certain lesions affecting the sheath, including manica flexoria tears and there's another abbreviation they use here, and palmar plantar annular ligament constriction are more prevalent in the Cobb breeds. The authors of this study have noted that in Cobb limbs where the skin and subcutaneous thickness are substantially greater compared to non-Cobb limbs, entry into the sheath is more difficult. This may be the result of increased risk of damage and affect the long-term outcome following the sheath tenoscopy. The Cobb limbs, the author often use an alternative instrument which is a custom-made double-rounded ended switching stick for the initial entry into the sheath. So they have a picture here of the different instruments here. I'll show them to you now. A is the Arthrex, which is a company name, arthroscopic cannula. B is a standard 4mm Arthrex conical obturator. And C is a 4mm double round ended obturator or switching stick. And so this is the imaging there. There you go. And of course you can see it here on the screen. And this is the cadaver limb showing the thickness of the horse limb. So pretty gross. But you can see why it's difficult. Why it's difficult to enter there with these arthroscopic equipment. So in this top picture here, hemostatic forceps spreading the thick skin and sub-Q at the digital flexor tendon sheath, portal site, and a Cobb limb. And then the bottom picture, thick skin, subcutaneous tissue, and skin folding in the Cobb limb. All right, materials and methods. Instruments. The tenoscopic images were acquired using a 4mm 30-degree forward angle arthroscopy by Arthrex, connected to the 4K processor, which is at a Arthrex arthroscopic tower. Here's another picture of their setup there. You see the tower in the background, that's the TV, and then there's the bottom of the hoof for the horse. In that picture, the hoof parameter measurements are hoof length, hoof width, and heel bulb width. And then for this picture here, this one right there, showing you the skin thickness measurements in a Cobb limb with, and also the subcutaneous thickness as well. Okay. Results. They have 104 limbs, 52 Cobb, 52 non-Cobb, 64 limbs, 27 left, 33 right, and 44 hind limbs, 21 left, 23 right. Regarding the breed type, Cobb versus non-Cobb, the mean hoof length, hoof width, and mean heel bulb width were significantly greater for Cobb compared to non-Cobb. The mean Cobb skin at 8.4 millimeters was twice thickness of non-Cobb at 4.5 millimeters. The number of attempts to enter the sheath, overall, the mean number of attempts for non-Cobb was 1.3 compared to 1.4 in Cobb limbs, but that was not statistically significant. When they analyzed data for individual surgeons, the boarded surgeons entered the sheath in the first attempt in all non-Cobb limbs, as opposed to residents who needed 1.7 attempts. The difference in number of attempts between boarded surgeon and resident for non-Cobb was significant. The difference in number of attempts between them and Cobb was not significant. For the Cobb limbs, it took 133 seconds to enter the sheath, which is longer than non-Cobb limbs at 112 seconds. This was more noticeable with the boarded surgeons entering the Cobb limbs at 115 seconds compared to non-Cobb at 46 seconds. In regards to iatrogenic damage to the intrathecal structures, it was significantly greater in Cobb limbs. A total of 25 out of 52 Cobb limbs, or 48%, had damage, whereas the non-Cobb was 27%. The Cobb limbs sustained longer cumulative lesions than the non-Cobb limbs. Obturator versus the switching stick. Overall, there was no difference between those two. And that's in regards to the number of attempts to enter the sheath, and then for the time to enter the sheath, the type of obturator did not have a significant effect on that. For iatrogenic damage, there was no difference, but 31% of the limbs had at least one structure that was affected using the obturator compared to 42% with the switching stick. And then in regard to surgical experience, boarded surgeon versus resident, the boarded surgeon overall entered the sheath in less attempts, 1.1, versus the resident, 1.7. The time to entry for the boarded surgeon, 80 seconds, and for the resident, 164 seconds. Those are all statistically significant. The boarded surgeon entered the sheath in non-cob limbs 4 times faster at 46 seconds compared to residents at 177 seconds. Boarded surgeon entering the sheath in cob limbs, 115 seconds. Resident, 151 seconds, but it was not significant. In regards to iatrogenic damage, 32% sustained damage to at least one structure with the boarded surgeon compared to 40% with the resident. And then in regards to overall iatrogenic damage data with tenoscopy, these abbreviations, they have so many. The digital flexor tendon sheath, the superficial digital flexor tendon was the most frequently damaged structure, 22%. And then I don't even know what PS is. I can't look for these abbreviations anymore. So for horse people, if you know, PS was damaged in 15% of the cases, and the deep digital flexor tendon was 12%. Presence of iatrogenic damage with the superficial digital flexor tendon, it was 21% damaged. PS was 15%. Deep digital flexor tendon, 13%. The superficial digital flexor tendon sustained full thickness penetration in 36.4% of damaged tendons and 7.7% of all the limbs. And this picture I'm going to show you here is a cob limb which sustained a full thickness penetration of the superficial digital flexor tendon alone. The transected palmar annular ligament is also shown. So here is this image for those who care about that. Okay, limb specifics. When all limbs, obturators, and surgeons were considered, there was a greater chance of entering the sheath on the first attempt in the forelimbs, 88.3%, versus hind limbs at 77.3%. The iatrogenic damage to at least one intrathecal structure was more than twice as common in the forelimb, 61.3%, compared to hind limb, 28.6%. The deep digital flexor tendon lesions were much more commonly found in the forelimb at 21.7% and the hind limb at 2.3%. And the mean deep digital flexor tendon lesion length was longer in the forelimb at 2.3 millimeters compared to hind limb at 0.2 millimeters. The calculated sensitivity, specificity, positive predictive value, and negative predictive value for tenoscopic detection of any damage to any of the structures were 92.1%, 93.9%, 95.4%, and 89.7% respectively. The overall accuracy for detecting damage was 93.3%. And so I'm going to show you here an image of a cob limb which sustained full thickness penetration of the superficial digital flexor tendon and deep digital flexor tendon, and then the proximal scrotum, that's the PS, is also shown. So that's this image here on the top. And then there's a scoping image on the bottom that is showing tenoscopic image showing some damaged fibers in the proximal scrotum, which is the PS, and deep digital flexor tendon and superficial digital flexor tendon are also visible within the sheath. All right, discussion. Overall, the results of the study confirmed the hypothesis that entering this sheath requires more time for cob than non-cob. This is explained by thicker skin and the presence of skin folds, complicating the identification of landmarks. The cob skin characteristics make it difficult to achieve and maintain sheath distension due to the elasticity of the skin. Distension of the sheath from the distal palmar or plantar pouch in cob limbs is complicated by the presence of skin folds, which causes an increased total depth of skin and subcutaneous tissue up to 40 millimeters in some limbs, and the length of a standard 1.5-inch needle. For this reason, both surgeons report the approach to the sheath. Let me see. Oh, this is likely, yeah. So for this reason, both surgeons report the PAS approach to the sheath to be more reliable in cob limbs. This may be due to the fact that the sesamoid bones give a more well-defined endpoint for the tip of the needle. In cob limbs, both surgeons performed longer skin incisions and used curved mosquito hemostatic forceps to bluntly separate the thick skin and subcutaneous tissue and expose the sheath outpouching. The extra steps performed in the cob limbs can explain longer time needed to enter the sheath compared to non-cob limbs where these steps are not required. All hoof and heel bulb measurements were significantly larger in the cob compared to non-cob. Hoof and heel bulb size can be a challenge when maneuvering the scope within the proximal part of the sheath. The type of obturator used did not influence these other factors. The boarded surgeon had less attempts than the resident, using the obturator but not the stick. Overall, the boarded surgeon was faster in entering the sheath than the resident. Regardless of the type of limb or obturator used, the effective experience was most noticeable in non-cob limbs. The surgeons were more likely to enter the sheath on the first attempt in the forelimb compared to hind limb, suggesting that entry may be easier in the forelimb. Furthermore, it's been reported that the PAL is longer in the forelimb than hind limb, increasing length of fetlock canal. The cumulative iatrogenic damage was greater in the cob. The difference between obturators or surgeons suggests that breed or limb types is the main factor influencing the increase of damage. The skin characteristics and difficulty maintaining distension in the cob limbs result in increased damage to the structures. The initial damage could have been further enlarged during the insertion of the stick or obturator and the cannula, other than just using a scalpel. Obtaining good quality ultrasonographic images may be challenging in thick-skinned horses. Overall, the superficial digital flexor tendon was the most commonly damaged structure, 21% in this study. This is in keeping with previous reports and can be explained by the superficial and more lateral location of the superficial digital flexor tendon at the level of the tenoscopic portal. In 8 limbs, there was full thickness penetration of the structure. Should this happen clinically, penetration of the tendon should be suspected and arthroscope withdrawn and carefully repositioned. The force needed to fully penetrate the superficial or deep digital flexor tendons was markedly reduced if a blade defect in the peritendon was present, similar to what could be created by the number 11 blade during portal creation. Apart from tendon penetration, to the other superficial digital flexor tendon lesions identified in the study were 10 millimeters or less in length, mean of 1.3 millimeters, while the deep digital flexor lesions were 40 millimeters or less in length with a mean of 1.4. Using the previously reported classification system, this would be classified as short tears. Other studies have used the sheath tenoscopy as the gold standard to identify lesions in vivo, to validate other modalities like ultrasound or contrast radiographs. In this study, specificity was excellent, sensitivity was good, but more variable depending on the intrathecal structure examined. Tenoscopy is a good test for detection of intrathecal lesions, although sensitivity is lower for deep digital flexor tendon and lowest for PS lesions. However, pathology of the PS is not common. The accuracy of the sheath tenoscopy was excellent, with values greater than 90%. So for those equine practitioners, this probably is helpful to you who perform this procedure a lot. And then for equine owners, just realize there are factors outside of just surgeon experience that account for why sometimes these procedures can be quite difficult. All right, guys, we'll see you again in the next video. Thank you so much. Bye-bye.